So this online lecture will cover home testing and monitoring devices in the PMPR 4170 Non-Prescription Pharmacotherapy 2 course, and this is Dr. Courtney Mosspan. And this lecture will be a little bit different of design in that it's a bit of a flipped classroom design. So this online lecture will provide an overview of the home testing and monitoring devices that are commonly experienced in practice or are important for you to have a little bit of a base knowledge about. And we'll cover an overview of the correlating disease, some key considerations for that test, a brief description of how to correctly counsel a patient to use the test, any potential interferences that can occur with the test that your patient should be aware of, and then also any special counseling points that you should be sharing with your patients in practice. Objectives for today's lecture are to first describe the market for home monitoring and testing devices, and also considerations you should have in recommending those products to patients. Should be able to demonstrate correct counseling for safe and effective use of home monitoring and testing devices. Should be able to determine appropriate use of these, and then determine when patients should be referred to a physician or when a product is not appropriate based on that patient's presentation. So what I really want you to be able to take away from this lecture design and this topic is key considerations that you should have in your decision when a patient presents to your pharmacy asking for one of these devices. I want you to be able to make an appropriate recommendation and provide key counseling points for your patients, such as anything that's going to interfere with the test and lead them to getting an incorrect result. And you just want to be able to help your patient appropriately and accurately use these tests, as they often do correlate to diseases that can have some substantial long-term impact for patients. References are listed here. And first, just briefly going to cover the market for products. So home monitoring devices have significantly exploded on the market since the first home pregnancy test was introduced in 1977. And there's been a continual growth because there's more and more products, and these products are getting easier and easier for patients to use. Interestingly, in 2006, the annual sales for home pregnancy and ovulation tests alone was $262 million, with an overall $4.5 billion in annual sales for these devices. So these are something that patients are willing to use and are spending a lot of money on. And some market forces at play are listed here. Interestingly enough, patients are more interested in their health and preventative care as a way to reduce healthcare costs by patients avoiding unnecessary doctor's visits. And they're also being used more just because of the burden on our healthcare system. There's a reduction in patient access and availability of the healthcare resources that are out there. So when you're selecting a device, you want to always keep in mind that these are designed to detect the presence or absence, so it varies based on the test, of a physiologic condition, and they can be used to monitor disease therapy. The FDA requires that these home tests perform as well as the professional use equivalent. However, that's assuming that the patients are using these appropriately, and so a lot of times patients can be quite challenged to use these and then are led to an incorrect result. Further selection criteria are listed here. There's both product variables and then patient-specific variables. So for the product, you want to consider how easy is it to read, is it difficult for the patient to perform. Presence of a control is generally desirable so the patient has something to compare it to. And then cost can also be a huge limitation, as many of these tests are upwards of $50 to $100. When looking at the patient, you want to assess the appropriateness of testing. So does the patient have risk factors for the disease that they're concerned about? You want to assess the patient's ability to accurately conduct the test and then interpret those results. And then consider any interferences in their diet, medication, sometimes lifestyle with the test results that may cause a false test result. And there are a lot of different tests available on the market. I have several listed here. This isn't even the full spectrum of what's available on the market, and we won't cover all of these, but just for you to keep in mind that this is a constantly changing market, that you're always liable, being a community pharmacist, to have a patient walk in the door and ask you if you carry it, ask you what your opinion is on it, or potentially ask you to find it for them. So the first test that we'll discuss are actually monitoring devices, and it's blood pressure monitors. And this is what I've encountered the most within my practice as a patient who wants a recommendation for a blood pressure monitor. And as you can see here, there's several different styles. The one on the top left is a digital wrist monitor, and then a digital arm monitor to its right. On the bottom left is what's called an aneroid blood pressure monitor, and so this is pretty typical or pretty similar to what you typically think of with a mercury cuff, except everything's all connected onto one device to make it easier for patients. And then on the bottom right is actually a new smartphone blood pressure monitoring tool. So for blood pressure monitors, there are 3 different main categories, being aneroid, so that again is that combined device that I showed you on the last slide. There's digital, which includes both wrist and arm. There are also finger monitors, but those have been found to be quite inaccurate and are not recommended for patients. And then the last device is the mercury column, and that's the one that you typically think of where you have the blood pressure cuff and then the stethoscope separately. Your mercury column is going to be your gold standard, but it's not really realistic for many patients to use. It takes a lot of coordination, and they have to have very good eyesight and very good hearing. And so it's not one that you really want to recommend for a patient unless they happen to be a nurse or a nurse practitioner or physician. Aneroid are the next most accurate device, but again, those are kind of difficult for patients to use. They are generally the cheapest. But if a patient's willing to learn, has good vision, has good eyesight, it can be a good option. And these are preferable as well because you can tell if they need recalibrated or not. The needle should always be at 0 when the cuff is deflated, and so if it's resting a little bit above 0, that's an indication that it needs to be recalibrated. Digital are going to be the most common choices at home. They're the easiest to use. Patients generally like them. They can store the results at home. The only issue with digital is that there's no way to know if they need recalibrated, and so commonly I'll recommend that a patient bring it in to myself, to another healthcare practitioner yearly, and have a test done sort of the old-fashioned way by the mercury column as well, just to test and make sure that it's getting similar results. Digital wrist cuffs are generally not a great option because the further you get down the arterial tree, the more variability there is in the blood pressure. However, these are a good option for obese patients because wrist diameter is the least affected area of the body by obesity. So digital wrist cuffs are good for obese patients. And then arm circumferences are listed here below. I'm not going to expect you to remember what circumference matches with which size. However, it's really important that you do kind of keep this in your back pocket and always help your patient measure their arm whenever they're looking for a digital cuff, and make sure that they have an appropriately fitting cuff. If it's too small for their arm, it can increase their blood pressure reading by 10 to 20 millimeters of mercury higher than it actually is. Another important thing to cover with patients who you're recommending a blood pressure monitor for are items that can interfere with that test result, which are all listed here. Stress is a huge one, and then tobacco and smoking may seem redundant, but tobacco can include chewless tobacco. Smoking, caffeine, and pseudoephedrine, all of the top 5 are all going to raise a patient's blood pressure and make it higher than their resting blood pressure. The bottom 2, a hot bath and shower and then eating, are actually going to lower a patient's blood pressure. For a hot bath and shower, it causes them to vasodilate, and then for eating, it redirects their blood flow to their stomach, causing a decreased blood pressure reading. So our next device kind of aligns with the blood pressure monitor, and I actually decided to include this when I was doing research on the blood pressure monitor, and those are smartphone monitoring tools. They're starting to come out with a few, and it showed here that as of January of this year, over half, 58% of American adults have a smartphone, and so these are becoming a more and more common part of a culture, and a lot of patients are interested in monitoring their health via their smartphone. I've had several patients that track their health data in a health app on their phone. And there's some fingerprint technology that's allowing for blood pressure monitoring on some of the phones I've heard. Again, that's probably not an accurate method because once you get into the fingerprint or fingertip area, it's got a huge variability, but it is something that I've heard from patients. The first one listed here is the AliveCor, and that's on your bottom left, and it measures EKG measurements. The caveat with this one is it has to be prescribed, and it is quite expensive. It's about $200, but you just snap it right onto your iPhone product and download the app and then place the fingertip over the key sensor for 10 seconds, and then you have an ECG measurement. And the next one in the center is a blood pressure monitor. It's the Withings Smart Blood Pressure Monitor. This one is a little bit expensive too. It costs about $130, but it seems to have fairly accurate results. You can create multiple profiles for it, and again, this one is only on the iPhone. And then the last one is the IBG Star blood glucose monitoring system on your bottom right. And this one is very expensive. I didn't see a price for just the connector, but your strips are quite expensive. It's $10 for $72 and $50 for $100. So these are much more expensive than what patients are used to. However, some patients like the convenience, they like sort of the technology associated with it. Something to consider though, especially with this blood glucose monitor, is it financially viable for the patient long term? And having that discussion with them. And I didn't get into it with these devices, but you also want to research how effective they are. Do they have any testing for safety and efficacy for patients? Because if they're not measuring within a good range of what your lab tests are, you really don't want to recommend them to a patient. Our next tests are cholesterol tests, and as you can see here, there's several different tests on the market. The first one on your left is the CholestTrack. And this test is a blood test where the patient would prick their finger and then place blood into a cassette, and there'd be a chemical reaction. The limitation with this test is typically it only measures total cholesterol. You can get it to measure HDL, and they have a women and diabetes test as well, but those two tests don't really say what extra is tested for women or what extra is tested for diabetes. The center one here, Checkup America, it can actually provide a full cholesterol panel including LDL, which is then sent away to a CLIA waived laboratory. So patients have to be aware that this one they do have to mail away, and it is going to take some time. And then the last one on the right is a CardioCheck, and this is pretty similar to a blood glucose monitor where it automatically provides the reading for patients. They also can test ketones and blood glucose. However, it requires a different strip and a different testing chip to code the machine, so it can get quite expensive. There's been variable reports about the accuracy of these tests. Consumer Reports tested the CholestTrack, a First Check machine, and CardioCheck, and it said for the CholestTrack and the First Check that the two tests had results that varied no more than 15% from the lab values, and so that they were fairly good to use, but a 15% variance is a pretty big variance in my opinion, and something that I'd really rather the patient get tested at a lab. And then the CardioCheck they indicated was often wide of the mark, but provided no specifics of what that actually meant. Another test that was a published study of the CholestTrack machine found that untrained patients obtained results that correlated well with a laboratory-based cholesterol reference. When looking at these tests further, while cholesterol is a major contributor to the development of atherosclerotic heart disease, which then can lead to heart attack and stroke and has a lot of impact on the heart health, their impact on the market is kind of questionable to me given the new guidelines, which you guys haven't gotten to yet. But in our old ATP3 guidelines, which were the old guidelines for cholesterol management, LDL was kind of your goal. You pushed your patient to a certain LDL goal, and that was what was thought to be effective for preventing heart attack and stroke for these patients, which none of these tests even really test for in the first place. But now our new guidelines abandon that LDL target and are placing patients on cholesterol therapy more based on their risk factors and disease states that they have. And so I kind of think that these tests have lost any place in the market that they may have had before. Their purpose is to help monitor for efficacy and adherence to their diet, exercise, and medications. And as I discussed on the last slide, the accuracy of these can vary greatly by product. When looking at the mechanism of action for these tests, it also varies based off the test. So the first test, the Cholesterol, is an enzyme reaction that produces a color change. And there's actually 2 spots on the measurement scale or on the cassette for the test. One of those indicates completion of the test so that it's time to read the test for the patient, and then the other indicator is the change that the patient matches up to the guide that tells them what their total cholesterol level is. The CardioCheck is a reflectance photometer, and so what that means is it works just like a blood glucose test. It's going to pop up a number for them, and it's the most user-friendly, although keeping in mind it does have the biggest accuracy concerns. And then our last test, the Checkup America, is a complete lipid profile performed by a CLIA certified laboratory. So this one is going to be the most accurate. It's going to provide the most well-rounded view of a patient's cholesterol. But again, it's kind of getting away from the direction of cholesterol management and standard of care for patients. There is an exclusion for self-testing for this, and that's for patients who have coagulation disorders or patients who are on anticoagulants. Our next test is a DNA paternity test, and we're just going to briefly touch on this one. And the only reason that I wanted to touch on it is just because it doesn't have really any value to the patient. Purpose is obviously to check paternity of a child. However, there's no real impact of it. The results are not valid for legal purposes. So if someone completes this test and verifies that paternity of their child's father, they can't take it to a court to then get visitation, to get child support or anything like that. And it is fairly expensive. It's $120 for the lab analysis, and then it's $30 for the kit. So you're looking at $150 and not really having anything to show for it. Not all states allow patients to purchase these, so that's something to consider based on where you work. However, the results are available fairly quickly. You can get them online 2 days later. For accuracy, the website claims that they are 100% accurate, but again, even if it's 100% accurate, a court isn't going to recognize that and hold the father to any legal responsibility. And then procedure for this is fairly simple. However, you do need cheek samples from the mother, the father, and the child. Just a quick swab of the upper and lower cheeks on both sides. Patients should rinse their mouth out before they complete the cheek swab, and then you just mail it off to the laboratory. The next test that we'll cover is our drug abuse tests, and these are ones that are fairly common for patient or parents to use or for employers to use. Usually it's not the patient themselves coming in wanting to use a drug abuse test, but they do have a fairly decent place in the market. It's estimated that 8% of Americans abuse drugs, both legal and illegal. Obviously something that we see a lot in our region here in Eastern Tennessee. And then this spans all age groups, all socioeconomic groups, all genders, and races. Symptoms of drug abuse are listed here. It can include red eyes, fatigue, drowsiness, chronic cough, and slurred speech, and then withdrawal from normal activities. And these can present as a singular symptom. You can have a mix of symptoms. It just depends on what the patient is abusing and that patient's specific tolerance level. But the National Institute of Drug Abuse does have a website where they maintain a list of drug abuse tests and what type of test you'd want to consider based on the suspected drug of abuse. The purpose of these tests is obviously to detect drug abuse. As I mentioned, the drug detected varies. You can get tests that monitor for maybe 1 to 2 drugs all the way up to 10 drugs. What's nice about them is they are anonymous, and as I mentioned, they're commonly utilized by small businesses for pre-screening for employment. additional impact is they can allow parents or caregivers to detect drug use early enough to affect the course of addiction, to get that person into treatment before they have been using the drug for a long time period, or before there's any sort of social or legal ramifications for the person. The accuracy of these tests is fairly high. However, there's a few special considerations. The first is to try and assess the length of suspected use and the types of drugs that the person suspects the patient may be using to recommend the correct test. You also want to encourage the person purchasing the test to consider potential problems with a positive test result before concluding that there is drug abuse, and consider the testing window. So some drugs are going to be metabolized out of the body fairly quickly, and it can be hard to kind of get a test in that time frame to get a positive result. Mechanism of action for these tests will vary based off the type of test. There's two different tests. The first is a urine test, and that is a immunochromatic assay, and it's just the same type of test result as a pregnancy test. There's different types of tests that can be a cassette or a little device that's placed in a urine sample, and these are good for detecting drug use within 2 to 3 days of testing. So they're going to test maybe a sporadic, occasional drug abuse that's more in a social type of arena. Hair tests are going to detect trace amounts of ingested drugs that have been trapped in the core of the hair shaft. And so these are better for patients or persons that you have suspected long-term chronic drug abuse. They can determine drug use over a 90-day period from just a 1.5-inch hair sample. And these have some different testing mechanisms of immunoassay and gas chromatography. And then there's a third form of saliva, but these are only marketed to employers in drug testing programs, so they're not something that you can get over the counter for a parent or for a potential small business. The exclusion to self-testing is your non-FDA approved tests have to be sent to a certified lab, and that will be found on the outside of the box if it is an FDA approved test. And just always discussing the limitations of the tests and potential interferences. They're not true exclusions to self-testing, but really important points to stress. And potential interferences are listed here, so that's something that's really important for you to counsel the person purchasing the test on. Decongestants can flag as a positive test result. Dextromethorphan or Robitussin can flag as a positive test result. Lomotil, which is an antidiarrheal, can. Any cough medication that has codeine, because that's metabolized to morphine. And then poppy seed or poppy seed paste, and that's in very large amounts. Most sort of habitual or occasional poppy seed muffin eaters aren't really going to flag a test, but always something to be cautious of. And then for the urine test only, these are kind of more interferences that a person being tested could have. They could add water to try and dilute the urine so that the test it can't produce a detectable level. They can also use bleach to try and skew the test, and then producing another person's urine. So if you ever recommend a urine sample, the person performing it should also immediately test the temperature once they're given that urine sample, and it should be between 90 and 100 degrees Fahrenheit. Something that's nice about some drug abuse tests is some of these kits provide telephone counseling to help parents recognize signs of drug abuse, to assist the family in creating a drug policy, and then they can provide referral to rehabilitation and counseling services as well. So when looking at a test, you want to always assess the drugs that are suspected of being used, the type of use, so whether or not it's chronic or short-term. Hair testing, again, detects longer-term use because it takes at least 5 to 7 days for hair to grow far enough from the scalp for testing purposes. And then urine tests are better for detecting low-level casual drug use. The next tests are fecal occult blood tests, or FOBT, and the purpose of these tests is obviously to check for hidden or occult blood in the stool, and that screens for potential colon problems. Rectal bleeding is an early and common symptom of colorectal cancer, And these can be used as an adjunct to more invasive tests to either be a first step for patients or sort of an additional step to make sure that any possible sign of colorectal cancer is being detected. The impact of these tests is that colorectal cancer is the second leading cause of cancer death in the United States, and in 2010 alone, the American Cancer Society estimated that over 140,000 cases of colorectal cancer would be diagnosed, and approximately 50,000 people would die from that disease that year. Colorectal cancer does have pretty poor prognosis, unfortunately, and it's caught more late in stage than some of the other cancers, and so it's difficult to treat and may spread easily, and so that's where these tests benefit for the patient and place on the market comes from. As for your accuracy, they can have a low level of accuracy. A previous study found that a 3-day fecal blood test only identified 24% of colon lesions, but when you combine that with sigmoidoscopy, which is the standard of care for colon cancer screening for patients, it's up to 75.8%. So it's not perfect, but it's definitely an additional tool to try and protect patients. And generally, these tests are beneficial for patients who have a high risk of developing colorectal cancer. So people who have a family history of it, people who've had intestinal polyps or have ulcerative colitis. And the incidence of colorectal cancer is associated with advancing age and then consumption of high amounts of red meat or processed meat. So those can be patients that you sort of triage, and this test is maybe an appropriate test. There are several different things that can cause blood in the GI tract, so it's always a delicate balance with these tests of someone having a minor symptom or minor cause of GI bleeding and then kind of causing undue worry because they think that they have colorectal cancer. But then on the other side, your patient may be that 25% that even with sigmoidoscopy it's not detected, and then they think that they're good and don't do appropriate follow-up for colorectal cancer, and then it gets diagnosed really late in stage. There are several different types of these tests available. There's toilet tests, which are the easy detect tests at the bottom. Those are the most common ones that I've seen. There's also stool wipes, there's manual stool application devices, and then there's also collection kits that can be sent to a laboratory. All 3 tests are pretty non-invasive, easy to use, and can be completed in the privacy of one's home, so there's not necessarily a preferred product. I feel that the toilet tests are generally the most patient-accepted, but all of these tests have fairly good results, or fairly equal results, and are fairly easy to use. Mechanism of action for these tests is that they detect blood in the feces by having an enzymatic reaction with the hemoglobin of the blood. For our easy detect test, again the one that goes into the toilet, a blue-green color indicates a positive test, and that's specifically within a cross that you'll find on the test strip. An important point for patients, if you were to ever recommend these, is that they're placed in the toilet after a bowel movement. And if you do recommend one of the application tools, you use a wooden stick to apply to 2 pads or wells. Exclusions for self-testing for these tests are women who are currently menstruating, and I generally recommend spacing it by about 2 to 3 days just to make sure that there's no residual blood from the menstrual cycle, because obviously the blood's going into the same area and you don't know where the originating location was for patients. Fecal occult blood test, the most important thing that you can do if you ever recommend one of these to patients is counsel them on special considerations or special interferences that they should know about. So first, as I mentioned, several GI disorders can cause blood in the stool, so you always want to kind of pad the test result a little bit so that if they do get a positive one, they don't necessarily have a moment of panic. NSAIDs, so your ibuprofen, your Aleve, and aspirin can cause enough gastric bleeding for a positive test result. Most pharmacists and most patients can sometimes think of that, but another drug that can cause enough gastric bleeding is steroids, and that's something that even pharmacists can kind of forget about, is that irritation that steroids cause to the GI tract and then cause a low-level gastric bleeding that may cause a false positive. Rectally administered medication should be avoided during the testing period. Other important things are that toilet bowl cleaners can produce false positive results. Patients should also avoid red meat for about 2 to 3 days before and during the test, because some of these tests aren't specific enough to human blood, and that may cause a false positive. And then finally, vitamin C in doses greater than 250 milligrams a day can cause false negative results. Moving on to our next test is hepatitis C. And hepatitis C is the most common bloodborne infection in the United States. There's 3.2 million chronically infected persons, and 85% of patients who become infected with hepatitis C are likely to progress to a chronic disease state. And hepatitis C can have some very significant long-term damage considerations. It induces liver damage and can result in cirrhosis or even liver cancer. And so it's really important to try and detect hepatitis C and detect it early for patients. Risk factors are all listed here. Injection use of drugs, that includes both illicit drugs and even steroids. And then sexual intercourse with multiple partners is another key consideration for hepatitis C. Obviously, the purpose of this is to detect hepatitis C infection. One of the most important points is that it should be completed 6 months from the suspected incident. So if a patient had unprotected sex 2 months ago, you want to refer them to a primary care physician, because it's too early for antibodies to be detected, but it's really important that the patient get appropriate follow-up. Additional purpose is to prevent infection of others and further limit liver damage, so patients should avoid alcohol or drugs such as Tylenol that may further damage the liver. And sometimes it can test against other forms of hepatitis and then potentially vaccinate against those. And the impact of this test is kind of limited. Patients may not know all the risk factors for hepatitis C, so they may not know that they should be testing, and cost may be a barrier. The test can be about $60 to $100. Accuracy is fairly good, though. There's no false positive results on file, but again, testing at the wrong time frame may produce false negative results. So that's the biggest issue and challenge with these tests. The mechanism for this test, as I alluded to, is that it tests for antibodies to hepatitis C, and patients must register a PIN online to have access to their test results. Their blood sample needs to dry appropriately, so for 30 minutes before sealing and mailing, but they do want to send it fairly quickly after, because it's very fragile, and they need to make sure that they have an adequate sample of blood in the testing pool or testing bag. There's no true exclusions to self-care, but you always want to consider when the patient may have been infected, and if it's a long enough time period for their body to have mounted an immune response. And you want to consider the patient likelihood of follow-up. So many of these patients are patients that are underserved, patients that have risky lifestyles, and may not perform follow-up, and they may get a test result that isn't really going to impact their life. And so a lot of times it's more appropriate to refer these patients to a healthcare provider and to try and get them in some system, some coordination of care, a home for people who are transitional or homeless, and to try and improve their health through that means versus these tests. HIV tests are very similar to your hepatitis C tests. There are more than 500,000 new cases of HIV each year, so that shows why these kind of have exploded on the market and why there's a lot of people producing them. Is there are a lot of cases each year, and 21% of people with HIV are estimated to be undiagnosed, thus resulting in unaware people, causing 54 to 70% of the new infections that we see each year. Several of these risk factors are similar to your hepatitis C, so sharing needles or syringes, sexual intercourse with an infected person, or being born to an infected mother are some of your most common ones. Your cost is going to vary greatly amongst the three. It can be about $40 up to about $80. For purpose for these tests, obviously you're trying to detect HIV. And similar to your hepatitis C, you have to give your antibodies a long enough time to develop. So antibodies can develop as it's short of a time period as 3 weeks, but they can take up to 6 months. So similar to your hepatitis C, you really don't want to even consider recommending this test until you hit about the 6-month mark, because you don't know if your patient's going to be developing that antibody level at 3 weeks, at 4 weeks, at 4 months, or at 6 months. So primarily the purpose is to refer these to primary care physicians if they do get a positive result, and to try and prevent infections of others. The impact of these tests obviously is to try and prevent chronic disease complications. Patients may not know all the risk factors for HIV again, so they may not know that they should be testing, and cost can be a barrier for patients as well, although the CDC does recommend an annual screening or routine screening for all patients aged 13 to 64. Research has shown that 75% of people will change risky behaviors once they know that they have been infected, and antivirals can decrease infection of others by 96%. So if a patient does complete this test, does get on medication, it can significantly impact the spread. And something that's nice about this test is many people are afraid, embarrassed to get HIV testing, so it provides privacy for at-home testing, and once they get that positive result, hopefully they'll realize how significant it is and will get the care they need. Accuracy for these tests can vary based on product. Our OraQuick test only detects 92% of infected persons. So you think 92%, that's a pretty good rate. If that were my test result, I'd be pretty pleased. But when you look at it the other way, you can miss 1 in 12 patients who are infected with HIV and continue to propagate that spread. Your home access test is going to have a higher efficacy. It's going to be about 99.9% accurate, but that's a blood test that the patient has to complete and then mail away. When looking at our mechanism of action, all of them are going to detect antibodies to the virus, but there's different methods to do so. Our home access and our home access express are going to be a blood-based test, so similar to our hepatitis C. They have to have an adequate sample, it has to dry for at least 30 minutes, and get it in the mail. Our OraQuick is going to be a cheek swab-based test. They have an absorbent pad to swab the outer surface of their gums, and then they place it in a test solution. In 20 to 40 minutes, the patient will then read it, and if 2 purple lines are present, that means it's a positive test result. The most important thing for an OraQuick test is the patient should rinse their mouth out before, and they should wait 30 minutes after drinking, eating, or brushing their teeth or doing any sort of oral care before they test. Again, there's no exclusions to self-care testing or to self-testing like our hepatitis C, but you want to consider those other patient factors. Our second to last test is going to be a menopause test. Menopause is defined as the cessation of menses for at least 12 consecutive months, and so that helps you determine whether or not you want to recommend a test for a patient. You want to ask them about their menstrual cycle. If a patient is having one, then not having one for a month or 2, but still having a cycle 3 to 4 times a year, generally a menopause test isn't really appropriate. They're in what's called perimenopause, and it's more appropriate to ensure that they have a primary care physician or an OBGYN who's aware of this and is helping to provide symptomatic relief for them. Menopause typically occurs at age 45 or 40 up to 55. Your average age of onset is going to be 51, so again, additional tools to determine whether or not this test may be appropriate for your patient. And menopause results from the decline and cessation of estrogen production, which then causes an increase in your FSH, or follicle stimulating hormone level, as it tries to produce more estrogen. Some common symptoms for menopause can include irregular menstrual cycles, hot flashes, mood swings, vaginal dryness, insomnia, and fatigue. So again, some additional things to keep in mind when you have a patient and you're trying to determine if the test is appropriate or not. Mechanism of action for these tests is again an antibody that's going to be specific to your FSH, and a positive test result occurs when that FSH is greater than 25. The most important point for patients on this test is that it needs to be completed twice to confirm results about 1 to 2 weeks apart, because the FSH is going to fluctuate throughout a woman's menstrual cycle. Again, for this test, there's no exclusions for self-testing. It's more important, though, that you help your patient determine if it's appropriate and helping get them to a physician that's going to provide symptomatic relief and symptomatic recommendations for them. Some special considerations if you do recommend this test are they're commonly urine-based tests, and dilute urine can produce incorrect results similar to pregnancy and ovulation tests, so they want to use first morning urine. A patient should not be on any form of estrogen, so an oral contraceptive or oral therapy, because estrogen is estrogen, and that may provide an inaccurate result because of impact on FSH. You want to determine any potential interferences with the patient, and then you want to discuss symptoms of perimenopause and assess if the patient has discussed with their provider, and most likely just refer them on to their healthcare provider. And our last test that we'll discuss are vaginal infection tests. There's two different forms. There's Vagisil, which is available online, and this helps females differentiate between a yeast infection or a bacterial vaginosis or trichomoniasis infection. And then the second test are urinary tract infection tests, and there's two different forms. There's the AZO test strips and then the UTI bladder infection test, which are both shown at the bottom here. These tests obviously test for urinary tract infection and are important because they're a primary cause for 4 million visits to primary care providers each year. Risk conditions that patients would be more likely to get a UTI are pregnancy, diabetes, kidney stones, urinary obstruction, or history of UTIs. Generally, women are more likely to get a UTI because their urethra is shorter and they're more susceptible to retrograde bacteria after they urinate. Symptoms to help you detect if a patient may be a candidate for this test or not are pain upon urination, frequent urination, blood in the urine, lower abdominal pain, or the sensation of an urgent need to go to the restroom or frequently and urgently needing to go to the restroom. The impact of these tests is kind of limited. You really need to assess the patient's reason for wanting to use the test. You should assess what symptoms they have that they think they may have a UTI, and assess if they just had a UTI and had just completed an antibiotic and how adherent they were. If a patient does perform this test and gets a negative result, but they're still having some of the symptoms that we discussed, like pain, urine in their blood, you should still encourage them to go to their doctor because there may have been an issue with the test and they still have symptoms of UTIs. The biggest issue with these UTI tests, you're kind of creating an additional step for the patient. Great, they found out they have a UTI that they most likely already knew based off their symptoms, and there's no antibiotics available OTC, so they're still going to have to go to their doctor to get appropriate therapy to treat the UTI. Accuracy can vary. Your nitrite-only tests or your UTI bladder tests have a low sensitivity, and so they're not really going to detect a positive test, but they have a high specificity, and so that means they're really good at telling you don't have a UTI. When you combine that nitrite detection with leukocyte esterase detection, which is a common marker of a UTI, it increases the sensitivity and specificity, which decreases your risk of false negative. And those combination tests are your AZO test specifically. And they have found in research in the past that there's higher accuracy in certain patient populations, being elderly, pregnant, and urology patients, which is convenient because those are patients that you're going to see UTIs in more frequently. Mechanism of action is they're detecting either nitrites and leukocyte esterase, which are common markers in the urine of when there's a bacterial infection. A key counseling point for patients is they should collect midstream urine so that they sort of clean out any outside bacteria that may be present but isn't actually causing the urinary tract infection. There are several exclusions to self-testing for these devices or for these tests, which are the most important thing for you to know. The first is a vegetarian or vegan diet, and that's because they don't produce enough nitrite. Tetracycline therapy is also an exclusion, again because they're not producing enough nitrite. Vitamin C, greater than 250 milligrams a day, and phenazopyridine or pyridium, which is a urinary analgesic. And that is an exclusion because that will change the patient's urine color to a red-orange color, which interferes with the pink test result that indicates a UTI. It's automatically going to become stained, and whether or not the patient truly has a UTI, it will come back as a positive test result. So that wraps up our tests and home monitoring devices that we're going to cover. And so when we come to lecture, what you guys will do is you'll work in groups to determine if you'd recommend a product or not based off a patient case. So there will be a patient case for each of the different devices that we discussed, with some of those key considerations that I discussed, like how long ago they potentially had unprotected sex, any potential interferences for things like your fecal occult and your vagus or your azo test strips for UTIs. So you'll work on those tests, and then we'll discuss them as a class to determine whether or not you'd recommend the test or not. And we'll also discuss sort of general pharmacist recommendations for each product. So my hope is that you have a more critical thinking, problem-based approach to these tests than a rogue memorization of a testing procedure and information that really isn't going to benefit you long-term in your career as a pharmacist. For the quiz for this lecture, it will be based off this online lecture. However, they're very simplistic questions that you should be able to find fairly quickly and fairly easily in the lecture, and are covering just kind of base concepts before you come to class for the lecture.